We really can't talk about weight loss without mentioning GLP-1s.
But the whole point of using them is for you to learn and change once and for all your habits.
I think people need to see it less of a substitute and more of an adjunct to kind of lifestyle. And people are not using it in a balanced fashion.
I've had clients put on muscles on GLP-1s.
Yeah. Tina, welcome to the show. We're going to be talking about weight loss today because, as you know, it's probably the hottest topic in health and wellness right now.
Of course.
And we really can't talk about weight loss without mentioning GLP-1s.
Mm-hmm.
And I think, what we've realized over time is that, these drugs, whilst they're transforming weight loss, we're seeing some additional, I think originally surprising effects on many other aspects of health. It's really making us think differently about metabolism as a whole, hunger, inflammation,
Absolutely.
heart health, kidney health, the list goes on, even biological aging. And over time, and I think as our maturity in practices has increased or developed, I would say that a lot of questions have been thrown up over this time. And one of the biggest ones is, are we prescribing it correctly? Is there a difference between, ethically evidence-based prescribing that's medically supervised versus this kind of, mass market, whether it's supervised or unsupervised, kind of quick fix type approach? What are the considerations when we're prescribing? What does a diet plan look like? How are we counseling the patients? What are we doing in terms of long-term follow-up? What's the next generation? What's the next steps? And I couldn't think of anyone better to get on the show than yourself. We've been working together. We've had the pleasure of 7 years now, I think.
Yeah.
And so we've been through the kind of full journey
Evolution.
together.
Yeah.
Because I think the early first generations, I started to prescribe in around 2014, 15, and then we went on to kind of some of the newer ones in around about sort of 2019, 20, which I'm sure we'll get on to talk about. But before I go on, give us a little bit of context to yourself, because you're one of the region's leading clinical dietitians. You've got a wealth of experience now. You have your own health journey. You focus a lot on women's health. Tell us a little bit about you.
Yes, of course. So like you said, I've been here since 2005 in Dubai, in the UAE, practicing clinical nutrition. So I started my career here. And it's true that the evolution of weight loss and weight loss methods and weight loss progress has been, I think we live in an amazing era for weight loss, to be honest. And it has made our work so much more interesting, because we did get to a certain point, I would say maybe 5-6 years after I started my career, where things were just repeating themselves with nothing new. And with nothing new, we wouldn't see much improvement in the clinic, with the patients. And it was frustrating for us and for the clients. So to live the era of GLP-1s and what to come is very interesting. So yeah, I've been working for 25, 26 years now in the field. Mostly weight loss. I would like to say, clinical work. Our clinical work is around other areas, but it's mostly weight loss. But obviously, weight loss and whatever comes with it. So there's weight loss as a result of menopause. There's weight loss as a result of, diabetes or insulin resistance. So there's always a medical factor to it. I shifted my practice around the same time when I joined DNA, actually. I had breast cancer. I was just healing from my treatment and my surgery and my chemotherapy. And I was reading so much about functional nutrition, hormones, inflammation, anti-inflammatory diets, nothing I had learned in university. So I had to teach myself everything again. And then the opportunity came to join DNA, which was and still is the #1 functional clinic in the region. So I was like, maybe this is a sign. So as soon as I joined DNA and we started working together, you also helped me a lot look at things very differently. And this is where I decided I need to focus more. And I studied functional nutrition for hormonal health. And it gave me great perspective into what's actually happening in women's bodies, including my body. And I think this is also what today's nutrition is all about. We no longer should be working like we worked 20 years ago. We should be specialized. We should focus on one area. We should fine-tune our skills in that area. Otherwise, we'd be all doing copy-paste diets.
Yeah, and it's interesting you say about the sort of the journey and the re-education, because I think that is the same experience for a lot of people who transition into, I guess, we're talking about a kind of functional medicine model.
Yeah.
What you're effectively practicing now is functional nutrition. And even, you know, if I look back to sort of 5 years ago, 10 years ago, some of those sort of convictions that I held, I look back at and think, you know, I was wrong. Or, you know, there's been an evolution in the science and we've had to adapt to the science. And over time, you obviously, it's a learning journey. You become sort of more educated. And if anything, your best education are the patients and the people that you're dealing with. It's every day there's something new that's happening. Just one thing I want to touch on. You mentioned about kind of dietetics education and how there's a big gap. Same with physicians, and you know, we see this when we're hiring physicians. There's a big gap between what's taught traditionally and really what we think is the best practice based on the latest available evidence.
Yeah.
Are you aware of, or have you seen any adaptation or changes in dietetic education in the last few years? Has it kept up to, or is it trying to keep up to date with science? And if not, where can dietitians go to try and empower themselves?
That's a good question. Curriculum-wise in universities, no, I haven't seen any change. Minor. I taught nutrition students a couple of years ago. So in the basic curriculum for the BS in nutrition and dietetics or nutrition science, we're still teaching the same subjects. And even the way we're teaching the same subject is still the same. We're using the same books. We're using the same references, which is not wrong because it's a science and we need to cover the basics. But I personally, when I would teach a course to my students, I would always bring in the functional aspect without sounding like I'm preaching something, and it would be very interesting for them because at least it opens their eyes to the possibilities. So in the traditional education, nothing has changed, but I'm hoping that things are going to shift slightly because I saw this when I was working, like people are starting to ask, should we add a course here? Should we change? Should we remove? Should we give them less time of this? So things are shifting, but very slowly. Now, I think now what's happening is just personal effort from the practitioners themselves. You have to go and look for further education in whatever interests you. If we're looking in, I mean, what I was talking about is the BS, usually BS as in Bachelor of Science, but we can find today specialties in masters. We can find much more refined specialties in nutrition and dietetics. So I think this is helping, but not everyone wants to go and do another 2-3 years of education into something, especially those who've done their masters already. This is where personal effort plays. You go and look online. There are tons of courses. There are functional schools. There are reputable schools that you can, specialize in certain topics online. But the key is to find your niche, to find what really excites you, not just because, it's a trend and everybody's doing it, we do it. So you need to see what you're good at. I always tell dietitians who ask me, junior dietitians, young dietitians, I always tell them, if there's anything that you've lived personally or someone close to you has lived it, it always helps because you already have the basics, this interest, this passion, rather than going and looking online what's trending. So find something that is interesting to you, because only then, when you niche your research and your studies, you will excel in what you do, and it will show in your practice.
100%.
Yeah.
Completely agree.
Yeah.
The only way you're going to give the level of devotion and attention is if you're actually passionate and genuinely love what you're doing.
Exactly.
Let's fast forward. Let's get on to the kind of the hottest topic, which is the GLP-1s.
Yeah.
When we're talking about GLP-1s, just for the audience, we're generally talking about semaglutide and tirzepatide. People are probably more familiar with the brands. So we had Ozempic, which was originally FDA approved, which is a type of semaglutide for type 2 diabetes. And then it got rebranded as Wegovy for weight loss, and then came along tirzepatide, which was originally FDA approved as Mounjaro, and now we have Zepbound for weight loss. I'm going to kind of start with a very sort of open question. Again, what's been the journey of how you look at these medications as a sort of intervention?
See, if you had asked me this question 5-6 years ago, I would have said complete nonsense. Why are we relying on medical help to lose weight? You know, weight loss is a simple formula, calories in, calories out. We've learned it in school. And today, with everything that I know and everything that we know and all the research and all the experience with our clients that we have, we can say like very easily, this is a breakthrough. This is the new era of weight management, of health, not only weight management, because today these medications are no longer studied only for weight loss. I was reading a research before I came about the possible relationship with cancer prevention, with all of it because of the metabolic changes and the decrease in inflammation and insulin resistance and so on. So today, the way I see it, it's yes, there will be the before and the after, and we are in the after, and I'm sure there's much more to come. And we need to be ready as dietitians, because I know physicians are much more trained on that, probably.
You think so?
Yeah. I mean, I would hope so.
Yeah.
But as dietitians, we need to be trained, we need to be educated, we need to go look for information, and we need to be very confident in the way we work with it, because contrary to what people think, this is not taking away any of our work. In the contrary, if anything, it's really funneling down the population that really needs us. And this is our time to shine and show that nutrition and lifestyle changes and behavioral changes are key to whatever these GLP-1s are doing. So without those changes, we've seen people take them alone and bounce back and regain the weight and then...
Yeah, and I agree with you. I think it's kind of amplified the people who are looking for responsible practitioners because they need some validation or support to their approach. I think what you tend to find, and we see the same with peptides as a whole, is you get that initial kind of hype, which may not necessarily consider so much the kind of science and the evidence. Then people start to realize, both on the practitioner and health-seeking behavior side, that actually we need kind of a structured, supervised plan to really sort of use these responsibly. I think your journey mirrors mine in the early years, and this is probably mainly to do with the fact that the sort of first, second generations weren't really that successful.
Yeah.
They came with a lot of side effects. They were okay at lowering blood glucose, but they weren't particularly that great at weight loss. So
Yeah, true.
I kind of shared your initial skepticism, and then they've gone from being sort of quite neutral to being very favorable in the right person or circumstances. I think it's worth just taking a step back for the audience to sort of just for us to explain kind of how they work, because I don't really see them now as a kind of weight loss intervention. It's more a sort of multi-system metabolic sort of activator or intervention. But just on the sort of the sort of practical sort of science level, the drug acts on multiple different organs. So we know that the pancreas will release more insulin. It will drive the glucose levels lower. And it's important to stress that it's a pulsatile insulin release rather than a sustained long-term chronic release of insulin, which is more pathological. We see effects on the ileum and duodenum, which is the small bowel, slowing of gastric emptying, slowing of movement over the bowel, increasing satiety. We're seeing effects centrally on the brain with appetite. We're even seeing effects on the muscle and the fat, which I think a lot of people don't realize, even some of the practitioners, where we're actually enhancing insulin sensitivity on a muscle and fat level and improving the metabolism of glucose. And then lastly, on the liver, we're reducing conversion of stored sources to glucose. So many different mechanisms of action that all kind of come together to sort of give this great effect. What's your kind of approach to patients when considering using them? Like, what does it look like in terms of your like assessment of that patient?
Okay, so I'm going to ask you a question first and then
Yeah.
I'll answer this one because this is a very common question I get. Like, if I want to go on GLP-1s, where do I start? And I always tell them you just check with your physician because there are certain tests you need to run before you come to me. So my question to you, when a client comes in and most of the time they know what they need, like they've tried everything and they come to you and they're hoping that you will give them the GLP-1. How's the journey like? Like, what do you start with?
Yeah, and this kind of comes back to sort of the evolution of my understanding of weight loss. Unfortunately, when most practitioners go, or I'm sorry, when most patients go and see a practitioner, they are typically following this model of a caloric balance,
Yeah.
which we know doesn't work sustainably for most people in the long term, if not 99.9% of people. I'm going to refrain from saying 100% of people because there are probably somewhere it does.
Yeah.
We've got to do a full proper assessment of that person because what is kind of imbalanced or an issue in person A may be very different to person B.
That's true.
And so as with any patient, it's a thorough history. And what we're trying to establish is what aspect of the lifestyle is it primarily that is affecting the weight and body composition. And so everyone's used to kind of hearing about the 4 pillars, nutrition, within nutrition, what they're eating, when they're eating, how often they're eating, over what time period. It's all important. Yeah. The makeup of their exercise, when they're training, how often, the mix of exercise. And with that, I think goes closely hand in hand, how well rested they are, how on top of their stress they are, how stress resilient, how well are they sleeping, which I think largely also overlaps into the stress component. Also as well, kind of looking at the personal history in terms of what was their weight when they were a child, even as far back as kind of, what was the weight of the mother during pregnancy, young baby, teenager, how many times they've dieted and yo-yoed with their weight over life. I think all of this impacts. And also going back to kind of family history as well. I think there's some transgenerational imprinting that happens. Plus gives you an idea, I guess, habits within the house, the kind of whole nature versus nurture thing.
Yeah.
Once I have all that information, then I generally would launch into doing some testing first.
Are there specific tests that you look for or specific biomarkers that you have to see absolutely, or it depends on the case?
Listen, it depends on the case, but more often than not, there is a kind of profile which is generally more focused around kind of cardiometabolic and hormones. Because by far and away, the most common causes that we see to weight loss resistance fall into the kind of insulin resistance metabolic syndrome category, the sort of adrenal stress category, sort of sex hormone status, whether that's everything from, testicular hypogonadism, low testosterone, and up right through to kind of in women sort of perimenopause. And that's not exclusive. I mean, aging itself will cause issues. And then just to give someone a clear example of that, you may have someone who lives completely the same lifestyle when they're 20 and has no issues with their weight management, but they try and do the same thing when they're 40 and their body's in a very different state. So we have to consider age and at what point of life they're at. Then there's other sort of soft markers like inflammation, for example. So we do have our sort of set portfolio of testing, but it's pretty broad and focused generally around those areas.
And this is where I think it's very important for people to seek help before starting them, because some people think if their insulin resistance is not very high or their HbA1c is normal, then they're not subject. I mean, they're not candidate. What you just mentioned is a checklist of 100 items. We could, you could look at and do the combination 2 out of 3, 3 out of 3, because it's like you said, you need to understand their lifestyle, genetic, because this will also affect for how long they're going to be on the medications or how well you expect it to work in the beginning. Yeah, so I think this is very interesting.
Well, and also I just want to add as well that I think there's a perception that most of the people that we're seeing are obese or type 2 diabetic. If anything, because you've seen a larger and growing proportion of the population doesn't fit into these neat categories and is probably more in that slightly overweight range, may even be kind of under muscled. And it's really that population that we're seeing adopt the GLP-1s, who it wasn't traditionally designed for, but are yielding great benefits.
Yeah.
And also as well, I think it's important to say that there are definitely patients who we see where their blood parameters may be completely normal, and whatever approach they're using isn't working. Have we used these medications in a controlled fashion in these sorts of people and seen success? Yes.
Yes.
To me, in the early days, quite surprisingly, which is why now I'm a lot more open to utilizing them, again, in a very sort of measured and controlled fashion, with a number of guardrails, and also just making sure that they're being followed up. One investigation I think is as important as any, which we haven't mentioned, is body composition analysis.
Yes, of course.
And it's amazing, isn't it? There are practitioners functioning out there, dietitians, doctors, who aren't measuring body composition, aren't doing any real sort of blood tests, and prescribing, forget the GLP-1s, putting
Anything.
someone on a weight loss plan.
Yeah.
Which is just, for me,
That's
mind-boggling.
That's true. And this is why when people come to me and say, I don't want to take GLP-1s because, I heard that you lose a lot of muscles. And then this is where education comes in. Like any weight loss method where you are going to lose weight very quickly, undereat your proteins, not eat enough calories. It's not only about the proteins, the total calories, you will be losing muscles. So it's not just because you're taking GLP-1. And so, yes, speaking of body composition, it's very important, definitely initially. And the most important thing is the tracking over time, because it motivates them. It gives you great insight into how the body is responding. I've seen, and I'm sure you've seen, people who did not respond to GLP-1s, because for whatever reason, whether it's behavioral or genetic or lifestyle, but we have people who did not respond. Minority, I would say, I would count them on one hand. But it's the body composition that would tell us all the story. I always tell my clients, without you telling me anything, when I look at your body composition, I know what you've done. I know if you were eating properly, if you were weightlifting, if you were taking your supplements, because it tells us a great deal of the whole story.
It may seem very basic, but just help people understand on a body composition, what they're looking at and why it's important, because you will have seen this. I've had people who've come in and they've been seeing another practitioner, they've come to me for the first time, and they've lost up to 30 kilos, let's say. But if you look at their body composition, fat percentage, it's hardly moved. We're talking maybe 2 to 3%. Can you just explain to people what is happening there?
Yeah. So basically, the body composition, I'll just give them briefly what it measures and what we look at. So the body composition analysis that we use, it's a technology called bioelectrical impedance that basically measures indirectly the fat loss, and it sends a current in the skin, and it measures the muscles, the water, wherever the current goes, and it does a calculation. And it's the machines that we use are 90% accurate, even 95% accurate. So this is to answer the question of people who say, but how does it know? Now, the only thing that is actually estimated, not really measured, and this is one of the most important markers, is the visceral fat. So the visceral fat is an estimation on these machines. What do we look at? Weight is the last thing I look at, to be honest. The first thing I look at is muscle loss, fat loss. So these two are the most important. And then visceral fat loss. Over time, we know that visceral fat, you don't lose visceral fat very easily. You could have lost 5 kilos of fat, but just 1 unit of visceral fat. So we have to know how to track it. Water retention, we look at water retention, water changes. And at the end, we look at the weight. At the end, weight becomes like, the difference that you're calculating. And so this is the most important thing. When people have lost 30 kilos, and out of those 30 kilos, 50 or 60% of it is muscles, you immediately know they were under eating, not only proteins, they were just under eating. They were probably not weightlifting, because there is no way someone would be weightlifting properly and be able to undereat this much. So it's a vicious cycle. You know, they took the GLP-1, they lost their appetite. The problem with the GLP-1s, by the way, people should know that once you're on GLP-1, you can no longer rely on your hunger for cues to eat, because it changes dramatically. You have to have a set, macro table menu. You have to be educated on what your body needs, and you just have to eat it. Because if you rely on hunger cues, you will end up under eating. So these are people who undereat. They're happy because they lose the weight on the scale. They're not doing the body composition. They're not seeing the muscle loss. And at the beginning, it's exciting. The energy is still there. They're happy. But then within a month or two, energy crashes. They can't sustain any activity. They start feeling dizzy. We see a lot of deficiencies, especially in women: iron deficiency, zinc deficiency, magnesium deficiency. She can't sleep. Her period becomes irregular. All of these are indications that the weight loss was not healthy. She lost more muscles than she's supposed to, and she could not sustain any activity, and that defeats the purpose. What's the point? What's the point of these medications? At the end of the day, yes, they're helping them metabolically, but the whole point of using them is for you to learn and understand and change once and for all your habits. Take advantage of the fact that your food noise is dimmed and start working on your habits. This is the key.
Exactly. I was going to say that's the key point. I think people need to see it less of a substitute and more of an adjunct to kind of lifestyle. And I think what you're also highlighting is that people are not using it in a balanced fashion. They're still taking that approach of escalating the dose inappropriately, or starting even at a dose that's inappropriate. And still, despite, even we see it in counseling, people still having this notion of creating a big caloric deficit. And the problem is that if you take the body to extremes, it will fight back.
Yep.
And then you end up causing sort of secondary other hormonal imbalances, changes in metabolism. And that's largely why you see that kind of rebound.
Yeah.
I mean, the pharmaceutical industry will throw the kind of studies at you that show that people sustain the, let's call it weight loss rather than fat loss, for many years, the years that they've been studying them, if they stay on the medication, which is all they're interested in.
Yeah.
But just on that point, if we look at the kind of composition change, on average, you're looking at around about a 40% loss of lean mass, and so 60% is fat loss, which is way too much.
Yeah.
And it's actually, what's interesting, and I didn't know this, it's very similar to what you see in bariatric surgery, and even correlates with a lot of the traditional dietetic nutrition plans. Now, I think we'll tackle that sort of in a second, and we'll talk about how we can kind of mitigate that. I first of all, though, want to just outline or highlight that there's a big difference, say, between someone who starts off at 130 kilos and you get them down to 80 kilos. Of course, someone like that's going to lose some lean mass. There's a lot of, non-muscle connective tissue.
Absolutely.
Whereas, for example, I think it's important that when we say, let's look at one of these people who only has, say, 5 or 6 kilos that they're trying to refine, say they're at 65 kilos, they're trying to get to 60, we're going to have far lower threshold, or say higher tolerance for them losing lean mass, because they haven't got the lean mass to lose.
I've had clients put on muscles on GLP-1s.
Yep, same.
Very serious ones. Many, actually. I'm not saying drastic muscle gain, but muscle gain. And this is something they have never imagined that they would see on the scale. Yeah.
So give us a little bit of insight into what are the tips, though, what for you, what's your experience? How do you...
So the first tip I would give people on GLP-1, my patients, is a mindset shift. So when you're on these GLP-1s, just because you're paying the GLP-1 and just because you're taking them, don't expect that the weight loss is going to be like magic. You know, there's a lot of work to be done, especially if you want to follow your doctor's prescription in keeping at a minimum dose. Because I know that both of us, this is what we prefer to work with. We are against jumping on doses because we've seen the effect of these. So if you want to take full advantage, taking the lowest, safest possible dose for you, then there's a lot of work to be done. So once they understand that this is what it is, then I put them on a very balanced macro protocol without obsessing over, you know, counting and measuring calories and so on. No, but I always tell them there's a minimum of protein you have to cover across the 3 meals, not just on one meal. And if you cannot finish this amount of protein, let's say someone intermittent fasts and it's impossible for them to reach their protein goals within one meal, we will have to try and increase the number of meals so that we reach. Of course, sometimes we use whey protein isolate, we use some supplements to help us. We use creatine sometimes, but when we're talking about just basic protein needs, one way of calculating is between 1.8 to 2.2 grams per kilo of body weight, depending on the gender, depending on the physical activity. So that's the baseline. And what people don't necessarily know, on top of the protein that they're taking on a regular basis on every meal, there's a certain amount of carbs they need to cover so that they can actually build muscles. So someone on GLP-1, especially someone with very high BMI starting GLP-1 and then going all crazy and cutting down carbs completely, this is not a good idea because one, we risk hypoglycemia and then they enter in this vicious cycle. And two, they cannot be maintaining their muscles with a very low intake like this. So yes, there's a certain amount of, obviously, carbs that are not inflammatory, certain types of carbs, because again, we go back to the inflammation because part of why these GLP-1 are doing wonders is because they're helping reducing inflammation and insulin resistance. So we have to play along at the same wavelength. Number 3 is the choice of proteins. So no, you can't just rely on smoothies and protein powders all day. You have to have a diversity. If you're not vegetarian or vegan, you need to have your intake of animal protein. I teach them how to choose the animal protein in a way that does not raise inflammation, in a way that gives them satiety, mainly grass-fed beef, chicken, hormone-free, antibiotic-free, fish, seafood, eggs, Greek yogurt, a variety. So the intake is very important. And then, and this is the most important factor, is working out. So for women, for the longest time, if I want to lose weight, I need to walk. You know, I need to do cardio. Yes, cardio is important, and for those who are already doing their cardios, I would never ask them to stop, but this is no longer enough. When you are on GLP-1s or when you are above 40, even if you're not on GLP-1s, cardio alone doesn't work. So they need proper weight training, they need proper resistance training, they need to understand why. Because if you do not stimulate this muscle, and if the body does not catch the message that it needs the muscles because you're carrying heavy, it will never help you build those muscles. Even if you do your weight training with very little weights and very few repetitions, and then you're super comfortable doing it, chances are you're not doing your job.
Well, and there were actually extensions of the original studies where they've had groups of people where they've trained them, and I think the lean loss was reduced to around about 20% from that 40. So it is kind of an evidence-based approach, and it's, you know, makes logical sense.
Of course, they just need to be guided throughout.
I mean, one of the sort of most challenging cases that we get, or certainly I get, and I'm sure it's the same for you, is someone who's a vegan or a vegetarian who already has low muscle mass, is carrying a lot of weight, probably not really exercising that much, maybe does some walking. How do you tackle that challenge?
This is the trickiest. But we manage. I usually give them a list of very high protein vegan sources, which usually they are taking, and I give them the combinations that they need to do to get their essential amino acids. We definitely need supplements, pea protein supplements. in most cases. And then they need to be aware of their macros needs in terms of calorie needs. But definitely there's an extra effort to be put there in terms of menu planning, in terms of, because it's not easy to get this amount of protein from vegan sources, because the quantity becomes sometimes, they would tell me, I can't eat this much. I already don't have appetite. And so we start, playing around, trial and error.
Well, and also as well, I think you're not comparing like with like. I mean, animal-based protein is generally up to around 100% assimilated, whereas a lot of the vegan-based sources won't be absorbed, and you're probably only sometimes getting as low as 30-40% of the actual protein content in that food. I think as well, something earlier you touched on, I think that resonates, is that, again, I think a lot of people, when they're looking at insulin resistance and sensitivity of muscles to insulin, people are just considering the input of removing either the amounts of glucose or carbs, let's say, that they're eating, or eating within a restricted time period. The input, whereas a lot of people just don't consider the actual output side, actually stimulating the muscle and improving the sensitivity of that signaling. Because I'm convinced that a lot of these people who hit a kind of threshold with their insulin resistance and weight loss is because they're not tackling that side. I think particularly those who are getting older really need to leverage off both the nutrition and the exercise, or it's not going to work.
That's true.
Another area I wanted to touch on is do you see a lot of kind of side effects, the classic ones being kind of nausea, constipation? I get a lot of people complaining of hair loss. How do you kind of analyze that? How do you approach it?
Yeah, so at the beginning, I prepare them for what are the possibilities so that they know what to expect. The most common side effect, I would say, especially with the newer generation, would be a slower bowel movement, a bit of constipation, especially at the beginning. Nausea, I don't see many complaints on nausea, especially with Mounjaro, for instance. Now, hair loss and weakness and fatigue and I cannot sleep and all of it has a lot to do with where they started from, because many come to us midway through their GLP-1 journey. So we were not the ones to start with them. So they have started those GLP-1s and their weight loss journey on deficiencies, not taking any supplements, or they're having, I don't know, thyroid issues that they were not aware of, especially women and especially iron deficiency. So this is something we tackle. If we see hair loss or any other symptoms that makes me think of maybe it's the thyroid, maybe it's hormonal, maybe it's iron, we just run blood checks and then we see if there are any deficiencies. We just up their supplements, change their supplements. In terms of bowel movement, I always tell them it's very important to just keep a journal initially, because sometimes you become overly sensitive to certain types of food. I highly recommend them initially to cut down on bulk fibers and vegetables and raw vegetables, because one, it increases satiety quickly and they need to take their proteins in, and two, it might disturb their gut initially, but gradually we reintroduce them. So we shift into more of cooked vegetables with proteins, and then gradually we shift into the usual raw vegetables they eat. But to be honest, I would say within 2, 3, maybe 4 weeks, things settle. Usually these symptoms don't last for long. And if symptoms last for longer than that, some people can't tolerate it, then I would refer them back to the physician and then, see if there are anything else that needs to be done.
I mean, one area that's surprised me recently is that some people who have chronic gut issues, paradoxically, one would think, is we're seeing improvements in IBS-like symptoms, for which I'm still kind of searching for a conclusive explanation. And I wonder whether it is, reduction in inflammation, maybe it's helping with the repair of the gut barrier function. There's inevitably some rebalancing or changes in the gut microbiome. But I think this is an area that I'm watching very closely and has surprised me, particularly when using them in low dosages.
I know, and I read recently a research linking IBD, inflammatory bowel diseases like Crohn's and ulcerative colitis, and improvement. And yes, there's definitely the anti-inflammatory effect. And I also think the consistency and stability in meals. These are patients who have been eating erratically, either snacking a lot or intermittent fasting. There's no routine. And when this routine comes, because it's easier for them to apply this routine, obviously the gut takes a break and digestion is more complete. And add to this that it is also a group of people who become more health aware. So they do their checks, they take their supplements, they seek help. So it's like a 360 approach.
Yeah.
But yeah, this is a very interesting area, and I'm also very curious to see where it's going. Now, the question is, and this is, I know, a very important question people ask, especially before they even start those GLP-1s. And this is what makes most of them reluctant, even those who actually need it. For how long do I need to take it? Is it for life? Do I need to stay on it? I saw or I read that when people are quitting or stopping them, they're bouncing back. So what's the point? Why do I need to go on them if eventually I'll regain the weight back? And this is a big thing. What is your take on that?
Yeah, I mean, it's a very good question. And I think this is kind of highlights the kind of conflict between, is something truly a chronic disease, in the sense that, do you need to live with it for the rest of your life, or is it something that is reversible? And the same is true to anything generally within the sort of metabolic health environment, because it's a predominantly lifestyle issue that can be reversed. I approach these type of medications the same way that I approach kind of all medications to some degree, in the sense that I only want to use the minimum effective dose for as long as I need to use them to extend that person's lifespan and health span. And so within that, there's definitely going to be different types of people. Now, the ideal scenario is that, you have your classic person who's trying to lose weight. You use it as an adjunct to assist them to get to a weight and maintain that weight. And if they are at a point they can come off and stay off, and use just lifestyle to continue that optimal journey, then that's the best case scenario. Are there then some people at the other extreme where they do need to stay on for the rest of their life? Well, listen, I guess it comes down to the fact that, is this person going to be better off being on a medication, and again, preferably the lowest dose required, and being in good health, a healthy weight, versus being off a medication and carrying a lot more visceral fat and all the complications associated with that? And if obviously, we're generally going to tip the balance in favor of the former,
of course,
then there is definitely a role. I think the important thing is that we're open-minded and that we're being very, thoughtful about how we're applying the medications, rather than just following the script.
Yeah.
Because, if you look at it kind of, no, let me just say, I forget that, I'm not going to say that. And then naturally there's going to be some people in the middle. So, we do have some clients whereby they're dipping in and out of the GLP-1s. And those sorts of cycles look very different depending on the individual. So there are some people who may take an injection, which typically, for those who don't know, is only meant to be weekly, or typically weekly. They may take one injection every month, or they may have a period of every 3 months where they'll take a month.
Yeah.
Again, there's no real set protocol. It's ultimately you as a practitioner understanding the science, knowing the individual, and then pairing that together to devise the best plan and approach for them.
Are there any dangers to taking them erratically, or does the routine make a difference? We know with the effect, obviously, the outcome, but in general, health-wise, are there any downfalls to doing that?
So I haven't seen any evidence that it does, but that doesn't mean that it can't, have a negative impact without the evidence so far. But I think ultimately, without the evidence, it comes down to mechanism.
Yeah.
And it doesn't make mechanistic sense to me that using it intermittently in someone who has a favorable metabolic profile would have a negative impact. If anything, it's probably actually rather going to have a more positive outcome, because we're dealing with a hormonal system, and if you're if we compare that to the kind of escalating dosage approach of a kind of long-term continuous use, I mean, a lot of the reason why people need to escalate the doses is because you're getting down regulation and adaptation of receptors and sensitivity.
Yeah.
Well, we're avoiding that scenario by utilizing it intermittently.
Yeah, and there's speaking of stability, there's this theory of the set point theory, which is now very much studied in terms of epigenetics as well. And one of the advantages actually of GLP-1s is that they're predicting that eventually it's going to also work on epigenetic in a way that an obese person or someone who has been overweight all his or her life, it has the genes have been switched on in terms of hunger hormones, satiety hormones. They've been switched on in a way to sustain this obesity. And now that the weight is changing and the weight is sustainably changing, it can be switched back off, and it would help on the long run. And this is why the predictions as well is that these people might stay for much longer than others because they've been living with overweight and obesity for longer, but they might actually get to a point where they can be off these medications because they reprogrammed their bodies. And this, I think, is fantastic. These are people who have never known the difference of satiety or the difference between physical hunger and emotional hunger and habitual eating. This is a change in people's lives dramatically. So yeah.
And I think it's kind of exciting to see what potentially may be in the pipeline and the kind of future of these medications, because I don't know whether you get it, but we already get asked, I probably get asked daily about even the next generation that's in phase 3 trials, retatrutide. There's a lot of excitement around that. Again, seems to have even more beneficial weight loss with lower lean mass loss. So it'll be exciting to see when that kind of formally comes out. There's even talk, we know that there's other trials going on into other hormones that may sort of facilitate weight loss in a different way, but also a step further incorporating some forms of potentially even gene therapy like follistatin to improve muscle mass or muscle growth at the same time as achieving the weight loss. So I think, as you say, these are here to stay. I think we're going to see a continual evolution that is going to, I think, transform more and more people's health, particularly in a epidemic now that's just been growing since the 80s. I mean, something's got to change. We know that there hasn't really been any successful epidemiological sort of intervention, or certainly policy intervention. So something has to radically change in the system of healthcare and how we approach these.
Absolutely. Like I said, there will be the before and the after.
Well, Tina, it's been absolutely fascinating. I mean, I'm sure there's a huge amount of other aspects of GLP-1s and weight loss that we could cover, and even beyond. We'll have you back for a kind of second show, but I think the audience is going to go away with a lot better sort of practical understanding of how we apply GLP-1s. Hopefully, if they were considering it or on a weight loss journey, it's something that they'll be more informed about if they're going to go and see their practitioner, and they, if they are going to take that plunge, understand what the appropriate approach in a responsible, evidence-based fashion is. Thanks again.
Thank you.